So with this one, it's my pleasure to introduce the first speaker, Professor Bernhard Wörmann from the German Society of Hemato-Oncology. He's a medical director located in Berlin and involved in all German HTA assessment and also heavily involved already in the European HTA framework. Thanks for being here.
Well, thank you very much for inviting me again. I was a little surprised to be the first one to talk, since we are probably the smaller players in all this, but probably it's also a good idea for the first 10 minutes to give you a glimpse on where we are in one of the major fields which has to be covered, which is oncology, and also the smaller field of ATMPs, which we mostly now place in hematology. I'm a hematologist, oncologist at the Charité University Hospital, so I can give you a glimpse on practice. This is just to impress you. That's a list of all cancer drugs that have been approved since 2011. I use that time point because that's the time point when the German AMNOG procedure started. And if you're very rapid, you'll count almost 200. Never had that wave. So if I talk to others about oncology these days, the greatest challenge these days is change. Because this doesn't come at one time point. If you look at your methodology, of course you look at a certain clinical trials, but we have to figure out how it gets into the whole picture. And I've decided just to show you two diseases, just to show how this happens now and what has happening just in the past 5 years. First is diffuse large B-cell lymphoma. It's the most aggressive, one of the most aggressive diseases that we have. It's the most common aggressive lymphoma. And this is just one of these algorithms. And the first impression again is, yes, it's very complex. But the message is, those are the new drugs which have been approved and in Germany put on the market in the past 5 years. So if you consider the course of a clinical trial to be about 5 years, then this all happened after start of a clinical trial. So when it comes to assessment, to approval, we have to consider what the current status of knowledge and also the current recommendations of guidelines which have to be considered. And then easily you can see in about half of these diseases in different situations, you have a different now mind setting than you had when the clinical trial started. This is quite important to refer to what we have with the PICO schema already. This is not just looking at new drugs. The most important thing is that they directly influence the comparator now, which may be not the same which you had in your clinical trial. Coming to oncology, I selected prostate cancer. Again, metastatic castration-resistant prostate cancer is a very common disease. It's kind of the last stage of a metastatic cancer, prostate cancer disease, when cells are no longer sensitive. Still, you have a number of different options. It's quite a complicated picture. But again, the message is, also in this disease, about half of the drugs that we commonly now recommend in 2024 have been newly approved within the past 5 years. Again, same message. Of course, every new drug in that new indication now sets a new comparator, which again was not the same which you might have in a clinical trial, but there are two more messages in that picture. The second is, we now, and that's only in the past year, we have decided that we have a new biological marker which we introduce very early when we start with these patients in that stage of disease, which is homologous recombination repair deficiency. And patients who have that status are building up a new subgroup. So you not only have new drugs, you have a completely new population, which you didn't have at any time before. And also selected this for another reason. Patients now start to challenge us. This is prostate cancer. Median age at diagnosis is 72 years. The hormone-sensitive stage is 5 to 10 years. So if you are at this stage of disease, you're in the middle, in your 80s. So patient advocates are discussing with us is really in that group of patients, overall survival is the best and only endpoint in the cancer drug development for prostate cancer, if probably quality of life shouldn't be at least at an equal level, or probably even more important, if an elderly patient at that stage decided what to take as a treatment. Thus, just to give an introduction what you're discussing about and how changes may also affect the process of JCA, which we're discussing in these 2 days. Well, this is very simple. Yes, we have different points. Again, we have approval. We know we have HTA in Germany. We have guidelines. Still, as a clinician, we're very interested to have them at the same level. Of course, they're looking at different things. We're certainly aware of that. But every discrepancy in like evaluation of a certain method, of a certain drug, might give uncertainty, probably to use a drug, not to use a drug, or even to get it in a wrong circumstance. That's a German experience, and I get a very simple picture now. If you look at my talk here, what I'm supposed to talk about, where the medical experts are important, yes, of course, like in our country, we are involved in the national appraisal. That will continue. When we discussed in the past 12 months, like in hematology with all 26 different European countries, less than half have this involvement of expert, even on the national level. Of course, now we have to get them involved into the joint clinical assessment. I think the most important part will be much earlier, really into the design of clinical trials and consultation, which I think is probably almost more important than the JCA, at my view, because we look into the future and make sure that clinical trials really have the picture that we need in Europe. Just to give you a number for numbers, now we are very much involved in Germany in that process as natural experts. If you look at the last number, just like last year from the GBA, we got 245 questions for expertise in that process, and more than half of them were oncology, hematology. So if you involve clinicians, it's quite a lot of work. Again, that also has to be organized. That's the point to discuss about. That's the last message. We have developed, or also, probably developed the sense that we have to change our approach to consulting experts. Prior, like 10, 15 years ago, we had some experts, they were nominated, always the same people, and they were nominated by the regulatory authorities. We now find that this complexity in oncology is not satisfied anymore by single experts, so we now have networks for all diseases, for all entities, and that's, again, quite a lot of a group, if we have like 3 to 15 experts, to have a common recommendation, but that is feasible. So one of the messages, again, also for these 2 days is, I think you also have to find a way to get back from single expert to find larger networks. We have discussed that already with hematology, and we developed a schema, which we're now trying to discuss with the national societies. It looks at if JCA is initiated, we have a group of experts, and usually we would take them from guideline groups. Not ask every nation to give their own comment initially, but to have a European guideline group, which probably also have the published guidelines in their responsibility, who they start to develop a PICO schema. This PICO schema then goes to the national societies, and they only have to cross-mark, have to tick mark, yes, that's what happened in our country, or it's not happening in our country. That's probably a way how we can get from the European level to get enough expert on the national experts to really get involved with an amount of time which is feasible. And then they could come up with a consensus document, and that could probably fulfill the timelines, which are very stressful. Sometimes pictures can be easier to transmit a message. So these are hermits. These are Meteora monasteries in Greece. They live in their caves, and these are what we probably thought 20 years ago. We have a hermit who thinks, who is independent, who has no conflict of interest, and who gives philosophical insight into a question. I think that's out. I think we now need groups who are on top, who work together and have a vision of the world. Thank you for your attention.
Thank you very much, Bernhard, for this great presentation.